to our 12:30 discussion. Today's focus is going to be a film analysis on The Evil Dead 2, Dead by Dawn, which of course is part of every medical curriculum. So, all right, well, ideas, where would you like or prefer to start? I think we should have a relatively straightforward idea of what character you prefer to analyze. Would that be okay to say, Ash? So, what did you say? Again, very generic. Let's avoid using any clinical terms.
He suffered very traumatic incident at the beginning where his girlfriend attacked him, and then he has to kill her.
So he suffered from trauma. And do we actually observe any behavior post-trauma that is a change from previous functioning?
Yes, we do.
So describe to me what you saw.
He was that he's losing control of his body, in particular his hand. He thinks his hand is out to get him, and he goes to the extent where he actually cuts off his own hand, but his hand still has the mind of its own, and repeatedly attacks him.
So that is one of the more iconic scenes in splatter horror, is that scene that you actually chose to go right to, right? We kind of brushed on this morning with regard to Maggie's character in Sound of My Voice. That is her report of what we as a group thought to be a case of, or fictional case anyway, of depersonalization. Now we have this incredibly dramatic, over-the-top representation of depersonalization, which the specifics point to what is referred to, albeit outside the medical literature, as the alien hand syndrome, where the individual does not feel that they are in control over their own physical processes. Alien hand syndrome and depersonalization here really are synonymous. Okay. What else did you say?
He seems relatively okay with things.
What do you mean by relatively okay with it?
He doesn't seem to be reacting very strongly. I don't know, it just seems like he would want to, he would either break down or he'd leave immediately. He doesn't seem to do that. He seems pretty lackadaisical, I guess, is a good word.
All right, so would it be fair to say that he's demonstrating Lavella and deference?
I don't know, I mean, he does have that one episode where he goes into like this maniac, this crazy laughter where he's laughing with the bust, and then everything else around the house starts laughing with him. So, I don't know if he's indifferent. I think he's just having like episodes like Psychosis.
What do you mean by everything around the cabin laughing along with him?
I mean, everything was laughing with it, like everything came to life and was laughing with him.
Can you give me an example of what it is that you observed as laughing? Anybody?
The deer head. Yeah, it started with the deer head first.
Uh-huh. So inanimate objects. Any thought of what's going on here? I mean, we think, I think at first glance this looks like a visual hallucinations. I would also suggest that individuals who experience, or the experiencing of VH is rare. So as clinicians, we always have to keep in the back of our minds that there might be something going on other than psychosis in general, and visual hallucinations in particular. And so, again, just keep that in the back of our mind for now. But when we have a patient self-report that inanimate objects are taking on lifelike qualities, including laughter, that's called animism. And generally speaking, and I know that in this particular film, it's easy to jump ahead to step 2, but generally speaking, when any individual, even in real life, comes to us with a chief complaint, and provides a history with regard to what might be referred to as an HPI, history of present illness, or even a past psychiatric history, the clinician should always start from the point that it is normal or culturally sanctioned until proven otherwise, right? It's always good to start off at that point, even though, doc, I'm seeing things that aren't there. It's easy to skip over that very quickly. At least acknowledge that's where we all want to start when we're hearing our patient's story, including fictional patients like Ash. When is animism okay? And there's two answers that I'm. Yeah, raise your hand. Okay. That's fine.
Children. It's a normal part of development. Helps them become more socially aware. Helps them to learn about the world around them.
So children is the easiest example. And there we're talking about when it's developmentally appropriate for the child's age. And I'm not going to get into milestones today. You're not talking to a child that wasn't a psychiatrist, so I just can't do that. On the other hand, the other answer, which is a kind of a cheapy cop-out, is that it is okay anytime that it is adaptive and not causing clinically significant distress or impairment. Right? That's the obvious. Right? That includes when, not when you're 5 years old, but when you're 35 and you're talking to your child and they fall, and it's you, not the child who hits the ground, bad ground, and the child smiles. Because that child smile is going to reinforce you doing that again. And doing that again actually is animism. Right? You're imparting life qualities. So you're 35. You're well out of that age range. But what you're doing is adaptive and not clinically significant. Is that what's going on with Ash? Not likely. No. Not likely. So again, even though all of us have jumped here very quickly, I just wanted to make sure we kind of know how we got here and that we're dealing with abnormal behavior. Now we can specifically identify that abnormal behavior, diagnostic terminology, visual hallucinations. What's our differential diagnosis? Yeah, so number one, due to the underlying effects of a medical condition, and as such, we have to consider the actual clinical syndrome of delirium in our differential. And what else is probably going to be at the top of our list? If that's A, if that's number one, what's number 1B?
Schizophrenia.
Even before there.
Substance abuse.
Exactly right. Which you would still get to if you said schizophrenia because, as we just spoke or discussed, to actually establish that diagnosis, we would have to investigate the underlying use of a substance. Question. Evil Dead 2, Dead by Dawn is a case study of a psychotic dissociative process due to an underlying medical condition as evidenced by there being something discreetly written in the script afflicting Ash. Right, we applied this to Maggie just a couple of hours ago or so with regard to identifying that part of the script that told us that she was undergoing multiple blood transfusions. Is there something similar going on with our character in this film? So the pause means no. There's nothing discreetly written into this script where this character has an underlying medical condition. The author, writer, director did not make it that obvious. Next question. Does the absence of that discrete information reassure you that this then isn't about psychosis due to an underlying medical condition? The answer is no. Why? And if it's easier for you, apply this to a real patient. Some of our patients are struggling with psychosis, and they tell you their past medical history is non-contributory. There's nothing there. For a consulting team, the primary team tells you that there's no underlying medical condition. Does that quickly reassure us that there can't be an underlying medical condition? Why or why not?
Just because it hasn't been diagnosed doesn't mean there's nothing actually underlying. It could be something like deeper that nobody really thought to look into, or it could be starting to present.
So now you're sitting in front of your laptop taking your shelf exam, and you're struggling with that very thought, that just because the clinical vignette doesn't spoon feed it to you, choice A, secondary to a GMC or medical condition, can still be the single best answer. What do you do? And the question is, it has everything to do with the risk factors that are posed in that clinical vignette. What two risk factors do you look at first? So sex and age, right? And unfortunately, for Ash, he is older and he is a male, so he has two risk factors that certainly would be consistent with psychosis being due to an underlying medical condition, despite the fact that the script does not spoon feed it to you. So we have to leave this in our differential. And we're going to apply the same logic to ruling out a psychotic disorder due to the direct physiologic effects of a substance as well. Now, unfortunately, for a substance that is a substance-induced psychotic disorder pertaining to this film, we don't have those risk factors. Anyone, male and female, can abuse a substance at any age. So the question that will be proposed, if there's no discrete evidence, does that reassure us? No, because it never should. So that one's even easier. We're always going to leave it in our differential, especially after evaluating the patient upon the initial assessment. That is the initial time you watch a movie. All right, so let's say that we're going to keep both in our differential. They certainly don't clarify what's going on in this film. And now we have to look at a psychotic process. What are some other signs and symptoms demonstrated by this character that may lead you to think that there is a psychotic disorder going on? And if so, which psychotic disorder? Now, we could take this in a stepwise progression like we just did in our case formulation pertaining to Maggie, the main character and the sound of my voice. But so as not to just duplicate the process and get everybody here bored. I'm going to just throw it out there. What do you think's going on from a psychotic disorder perspective here?
You're talking about Ash, right?
Yeah.
I thought his, he was so violent throughout the movie, and I think that that's noteworthy, especially if we're considering like a substance-induced psychosis. With like really violent behaviors, we might think about like PCP intoxication or something like that, and keep that on our differential in terms of what would be causing it.
No, I agree. Matter of fact, the main character in the remake, that is the remake of Evil Dead 2, and I'm not talking about the third part of the trilogy, I'm talking about the remake, is someone who in the script is afflicted with heroin. So, it's not Sam Raimi, but the producer just throw that at you. The director just throw that in there, just to kind of make sure that they're holding us to task. So I agree. We have to keep substances in general, and to the extent that we're thinking a hallucinogen, which I think would start our list, and that element of violence, that the hallucinogen called PCP would be itself at the top of our list. What are the three subclasses of hallucinogens? What type of hallucinogen is PCP? The dissociative. So that in and of itself, that is the dissociative as a subclass, should be at the top of our list, given the dissociation that we see this character demonstrate. Again, the alien hand syndrome, otherwise referred to as depersonalization, that's a dissociative. PCP certainly would be at the top of the list. What are the other two subclasses? Hallucinogens. Psychedelics. Somebody give me an example of a psychedelic? LSD. And finally, the deliriums. Usually you're talking about either recreational substances or medications with significant anticholinergic side effects. Deliriums. So psychedelics, dissociatives, deliriums are the three subclasses of hallucinogen. Again, nothing discrete in the script to allow us to stop this conversation right now, but definitely in our differential. What else do you think's going on?
Like What's an example of a delirium?
A delirium would be Benadryl. I'm going for the soft toss, Benadryl. And this comes up on shelf exams all the time. Individual, perhaps in their 70s, with difficulty sleeping. They are administered, quote unquote, something, and then you get a call 30 minutes later that the patient is now confused and agitated. Right? Benadryl. Anticholinergic side effect, delirium, delirium.
And then also you put things like the H2 antagonists, correct?
Antihistamines also. Any general rule, and if there's any pharmacists in this room, I apologize ahead of time. But the general rule is that anything that antagonizes the muscarinic receptor, the M1 receptor, cross-reacts to the histamine receptor as well. That's the H1, Benadryl, and the H2 receptor antagonists too. So yes.
When they get there, does he say that he's going to go get them drinks? I can't remember. She's changing, and he says something about getting them drinks. So should this be like DT? Does anyone remember that? When they arrive, he asks.
Yeah, he gets a bottle of champagne, I think, from like the next room.
Yeah.
So that's when she gets like
So when
So-
we're talking about substances, could it be something like a delirium?
Let's talk about that. So what are the three ways in which alcohol can induce psychosis? So you mentioned one, during its withdrawal state. Right? Alcohol can induce psychosis during the withdrawal phase. And there are two withdrawal phases due to alcohol that may appear on your shelf exam. What are they?
Delirium tremens.
Right, so one is alcohol-induced delirium, otherwise referred to as delirium tremens. What's another one? Alcoholic hallucinosis. So these are two what are referred to as complicated withdrawal states, inasmuch as they have hallucinations as part of withdrawal. One is called alcoholic hallucinosis, one is called alcohol withdrawal delirium. In both cases, your patient may be, by definition, be psychotic / delirious. So you go down to the ER, you evaluate, the patient does identify that there are spiders going out of the wall, and you are covered in snakes. Their blood pressure and pulse are elevated, indicative of acute alcohol withdrawal. Is this alcoholic hallucinosis or alcohol withdrawal delirium? How do you tell?
The time frame.
Time frame, unfortunately not. Pathognomically, shelf exam, day 3, hospital day 3. But it doesn't really differentiate one complicated withdrawal state from the other. Both may occur at day 3.
you have normal vital signs, but you see instability in DT.
Maybe there might be a better way.
Insight into like if the hallucinations. If you're concerned about the hallucinations and what you're seeing and think this maybe not real.
Go with that. I want more.
In delirium, there would be a lot more sort of confusion.
That's it.
Yeah.
Confusion. Remember, delirium is defined through confusion. It's defined through a changed sensorium. Alcohol hallucinosis is not. The patient in alcohol hallucinosis is likely to be awake, alert, and oriented, despite their hallucinating. They're not going to be delirious. If they're delirious, that's alcohol withdrawal delirium. So in the absence of achieving or reaching the threshold for delirium in that withdrawal patient, your single best diagnosis would be alcohol hallucinosis to explain those spiders and those things. Do we think that's what's going on here? Maybe not. What's another way alcohol may induce psychosis?
Drug interaction.
More specific?
Like if you mix alcohol with another drug, cause hallucinations.
Always keep that in mind. So that's going to be the fourth way. That's not the alcohol, but it's actually the co-occurring or the comorbid use of another substance like hallucinogen that itself is inducing the hallucinations. We're still looking for two more ways that alcohol specifically can induce psychosis. I heard it? It's hard with masks on. I can't see your lips moving when you said that. Right? The intoxication phase, absolutely. Now here, we're primarily dealing with alcohol by content, otherwise referred to as proof. So alcohols that have a significantly high alcohol by content can induce psychosis just by drinking them and becoming drunk on them. Right? Unfortunately, champagne is not in the top 5. Okay. Everclear is, 151 rum is, there's a Polish vodka that is, absinthe, but not champagne. All right, so there might be a third way here. And that's the long-term sequelae called the Wernicke's-Korsakoff syndrome. More specifically, the Korsakoff side of that, Korsakoff psychosis, where due to the chronic alcohol use, Ash's thiamine level is depleted, resulting in the syndrome hallmarked by retrograde amnesia, anterograde amnesia, confabulation, and aspects of Korsakoff psychosis, including perhaps seeing things on the wall that are inanimate, singing to him. God bless you. Could that be going on here? Of course, if we watched the prequel and we saw evidence of Wernicke's encephalopathy, boy, that'd be kind of cool. Anybody here watch the prequel? Unfortunately, Evil Dead, the original, is not a true prequel. Evil Dead 2 is really a parody. It's not a true sequel. So we really don't have a prequel. Which is why when I assigned this film, I reassured you, you don't have to see one, because there really is no true prequel. But if one did exist, then certainly if there were aspects of Wernicke's encephalopathy, that would be an interesting take on this. So that remains to be seen. If we thought this may be due to Korsakoff psychosis, what would our treatment be? Other than the general treatment of, well, I should say, let me just button up. What would the treatment be? What's the cause? No, that's for the obtunded patient that might cause the situation. We're going to get to that in a second. Well, thiamine. Thiamine replacement. Now, unfortunately, where he is, he's not going to get proper treatment because thiamine, in this case, needs to be repleted through the IV. 500 milligrams TID IV until resolution of symptoms, until he stops seeing trees come to life. So we keep that in a differential here. On-the-shelf exam. This is not going to present to somebody moving into a cabin in the woods and then demonstrating signs that may be suggestive of Korsakoff psychosis or the Wernicke's-Korsakoff syndrome in general. Instead, it's going to be somebody who comes in obtunded or comatose in the ER and they're provided glucose and Narcan. And then 24 to 36 hours later, they're acutely delirious, confused, with a change in sensorium. The reason or the cause is due to the effect that glucose has on the Krebs cycle, converted to pyruvate, and then in the first step, catalyzed by pyruvate dehydrogenase complex. I defy you to ask a psychiatrist what the importance of pyruvate dehydrogenase is, because none of us would care to know, to be totally and blatantly honest with you. What we do care about, though, is what it's complexed with, and that's thiamine. Because if you rev up that cycle, you are depleting any remaining thiamine stores, precipitating a Wernicke's encephalopathy. So always provide that substrate, thiamine, with glucose or before the glucose in a comatose patient, so as not to precipitate the Wernicke's encephalopathy. So I think that's what you were getting at. I didn't see Ash being administered any D10 or D5, so I think we're safe there. Although he may need he may need thiamine nonetheless, in as much as we think that the Wernicke's-Korsakoff syndrome, specifically the Korsakoff side of things, Korsakoff psychosis, may be what Evil Dead 2, Dead by Dawn is really about. What else is our differential diagnosis here? Let's say we rule that out. Now we're getting to a mental disorder. Where do you want to start?
Well, we have to like ask ourselves the questions: is there evidence of substance use? Is there evidence of a medical condition? And then from there, we have to, if we think it's more like psychotic, we have to, and specifically schizophrenia, like we talked about earlier, we have to rule out all the other disorders.
That's exactly right. After all this discussion, if, as clinicians, we conclude that we don't think that there is a substance or an underlying medical condition inducing what we are seeing, then we're going to have to look at this as being attributed to a mental disorder. And I think most of us would look at a psychotic disorder first, and specifically schizophrenia, in as much as it's usually the psychotic disorder we think of when we first address situations like this. Any evidence to support that this film is actually a case or a fictional case of schizophrenia? Any evidence in this movie, discrete in the script, go against that?
I mean, so I know that we're focusing on Ash as the main character, and I guess we're looking at everything through Ash's eyes. But if it were to be a case of, schizophrenia, everybody is kind of having the same shared experiences, and I mean, before they all die, they're talking about it with each other, like what they saw, and it's kind of having the whole experience together. So wouldn't it be a little bit unlikely that everybody would have hallucinations in the same kind of theme or genre?
Great, and that's exactly right. And that would certainly support this being either substance induced where everybody partook in the substance, or maybe even a medical condition that somehow people are there being a contagion where everybody has the same underlying medical condition.
Like an environmental exposure.
Yeah. Either environmental exposure or toxin, or even another substance that we didn't see in the movie beyond the champagne that everybody was using. Right. So that certainly would go against schizophrenia here. Absolutely. The other thing that I think we pick up on is that there are significant dissociative features here as well. We've actually initiated the conversation with regard to the severe form of depersonalization, and then ultimately in derealization with his thinking that his environment, his surroundings, are unreal in some way, to the extent that they're singing to him, moving and talking. So with those severe qualities under the rubric of depersonalization, we do have to remind ourselves that this does not necessarily rule against schizophrenia per se, because individuals with this condition, schizophrenia, can actually experience elements of dissociation. So it doesn't really rule against it, but then again, the clinician should be cued that your differential should broaden nonetheless. Looking at it from a textual perspective, that is not only include aspects of other psychotic disorders, but also dissociative disorders as well. So is everybody here comfortable then in saying that we would then include depersonalization, derealization disorder, and that perhaps this is the most likely diagnosis? Or is there more investigation within the dissociative disorders that we should undertake? I'm okay with more investigation. I mean, everybody's checked their watches. We have patients to see. But as long as we have time left, we can actually investigate this a little more, i.e., let's review the dissociative disorders prompted by the case study of Ash. Somebody's experiencing clinically significant depersonalization. Somebody's experiencing clinically significant derealization, or both. We actually start out by thinking, all right, depersonalization, derealization disorder. The next question for the clinician is whether or not there are gaps in memory that cannot be attributed to normal forgetfulness. Because if there are, we have a condition called amnesia. And similar to every other mental disorder, we have to rule out the underlying effects of a substance and medical condition. And once investigated and ruled out, we can then arrive at the diagnosis of dissociative amnesia. Is there any evidence of that here?
I think so. When he's possessed by the demon, recall that episode at all.
All right, next question. Is there some apparent wandering away from his home with an assumption of a new identity?
When he's possessed by the demon.
So maybe, right? And as a matter of fact, if anybody here watched the Evil Dead franchise before, you guys fans? You know that in Evil Dead 3, Army of Darkness, he becomes the anti-hero. And then remember that he used to work in a convenience store. So, oh boy, does he have a different identity. Now, having a different identity is different than having or switching to a different state of consciousness. Right? Having a different identity is different. Right? The individual is still aware of who they are. They're still aware of their station. But instead of calling themselves a physician, now they're a mechanic. Instead of calling themselves a cashier, they're calling themselves I'm not even sure what title he would have in Army of Darkness, Crusader. So there's definitely, although you have to cheat, a change in identity. And boy, does he travel away from one's home. He's up in times BC. Metaphorical nonetheless. Is this film, Evil Dead 2, a fictional case account then of dissociative amnesia with fugue? Because you can either have dissociative amnesia with or without fugue. It sounds like he's in a fugue state. And the answer is perhaps, but we have to investigate even further. Because while dissociative amnesia, generally speaking, will account for those feelings of depersonalization and or derealization, you wouldn't make both diagnoses. So too might dissociative identity disorder explain all of the above, considered to be the most severe form. And in that case, we do see what is referred to in the wiki as bad ash. Take over his conscious awareness. That's much more than a change in personal identity. It takes over his entire conscious awareness. It's an altered state of consciousness. And this movie may actually, in fact, be about DID. Matter of fact, it's interesting that up until about 2013, we've used movies like Evil Dead 2 about possession to metaphorically teach this stepwise process of evaluating for DID. But with the publication of the DSM-5, that is in 2013, things switched. Anybody know what the change was in the DSM-5, the actual edit? That when defining DID, that altered state of consciousness or awareness that takes over one's awareness, the edit text was, that may actually be experienced by a state of possession. So while it was metaphorical prior to 2013, with the publication of the DSM-5, it actually became written in the definition. The individuals who are possessed may be evaluated for DID. And that's exactly what happens here.
Why did they have that in?
You know, you have to, the easy answer is I don't know. You have to actually look at the task force's publication supporting the edits to the most latest revision of the DSM to get that real answer. I don't know. But they did add it in, maybe because people like me were using it metaphorically so much, they finally said, enough of this, we have to actually change it. That really happened though. But it was a change in 2013, that it may be experienced by possession in some cultures. And that's what may be happening. And I think it's really interesting that it happens here because it really does remind us, especially when we're taking our shelf exams, that in the most over-the-top dramatic presentation or over-presentation of depersonalization where he cuts off his own hand, the single best diagnosis for Ash still isn't depersonalization, derealization disorder, because that aspect is seen in the context of a larger illness that is likely called DID, as identified by bad Ash taking over his conscious awareness, resulting in amnesia when he actually becomes good Ash again. That amnesia as well would not be a separate diagnosis because it's accounted for in the primary disorder, DID, even when with fugue. all of this discussion about a dissociative disorder is only made when the individual's reality testing remains intact. And that is a subject of debate, because if in fact we deem that Ash's reality testing does not remain intact, all of this may be attributed to a primary psychotic disorder such as schizophrenia. So we're circling back to that nonetheless. We may end up with two diagnoses, because if, and it's a big if, that does happen where we think something like schizophrenia is our single best diagnosis, we still probably have DID as a secondary diagnosis in this individual. Other thoughts?
Thinking about schizophrenia, so we don't really know about any of Ash's backstory, but provided this is his first, schizophrenic break, what's the data behind the severity of one's first psychotic episode if they have schizophrenia? Is it usually more mild or more severe?
So individuals who have the initial onset between the ages of 18 to 25, I wouldn't call it mild, but it's more typical in presentation, including a prodrome. Despite that, we all understand as well that the prodrome is usually retroactively misdiagnosed as depression, social isolation, usually failing grades, either college or graduate school. That is being clinically significant, and likely misdiagnosed as depression, but then with the onset of psychosis and the readjustment of the primary diagnosis, kind of reframed as prodrome. So it's not necessarily that it's mild, it's that it's prodromal. And that might not be the case with later onset. Now, late onset is relatively rare, can happen though. But when it does happen, it is usually atypical in presentation, and that could mean absence of that prodrome, which may be happening here. And we don't know the prequel. Other thoughts about Evil Dead 2? All right. Again, I think the major teaching point here is twofold. You're never going to forget that scene with regard to depersonalization, yet you're never going to forget the clinical pearl that it doesn't matter if in the context of DID, because DID is still the most likely diagnosis. That is bad Ash with regard to what we see taking over his conscious awareness. And that becomes our single best diagnosis, with a primary psychotic disorder probably as a comorbid diagnosis if we think that Ash's reality testing does not remain intact. All right, we'll end it there. Thank you, guys.